So I'd like to start this talk by talking about a tale of two people, the Pima Indians. The Pima Indians, as many people in this room may know, are tribes that are found primarily on the Gila River Reservation just south of Phoenix. There's another reservation that's actually just up in the Scottsdale area, but primarily the Gila River Reservation. And the Pima Indians of Arizona have the highest prevalence of diabetes of any group of individuals anywhere in the world. They are the highest rate of any solitary group in the world. Now, what people don't necessarily know is that there's a second tribe of Pima Indians, and they're located in Mexico in a place called Macoba. And we know from genetic testing, we know that these two groups of people were separated by forces that we don't really understand somewhere around 700 to 1,000 years ago. So pre-Columbian, this group of people wound up in two very different places. But we know from modern genetic testing that the people who live here and the people who live here are more genetically similar to each other than they are to all the people who live in between them. So we actually really know these are two tribes of the same ethnic group of people. These are the relative rates of diabetes in the Mexican Pima and the American Pima. So in Mexico, the Pima Indian men, about 5% of them will eventually go on to develop diabetes, and the women, about 8% will eventually go on to develop diabetes. In the United States, the men, about 34% will go on to develop diabetes, and the women, about 41%. That's a staggering difference of two groups of people. We have genetically very similar populations, an enormous difference. So let's look at the lifestyle of the Mayacoba and the Arizona Pimas. The Mayacoba Pimas live primarily in a subsistence farming environment. So almost all of them are farmers. They have relatively little, they're actually fairly hardworking, but relatively little modern conveniences of farming. So basically they're engaging in relatively backbreaking work all the time. So the average man is working physically, engaging in physical labor 33 hours a week. The average woman, 22 hours a week of physical labor. They're eating a diet that is primarily carbohydrates. About 70% of their diet is carbohydrate, 15% fat, 15% protein. The Arizona Pimas, on the other hand, are living on a reservation. They are generally not engaging in a great deal of farm work or much physical labor. Men are working only about 12 hours a week, women only about 3 hours at physical labor. And their diet is 50% fat, 30% carb. Most of that is non-complex carb and about 20% protein. Obesity rates among the two groups. In Mexico, about 7% of the men and 20% of the women are obese with a body mass index of over 30, while in Arizona, 64% of the men and 75% of the women in adulthood meet the criteria for obesity. In Mexico, fewer than 3% of all of these individuals under the age of 45 have type 2 diabetes. So basically, type 2 diabetes, while it does exist, almost never begins until you're over the age of 45. That is not true in Arizona, where we see type 2 diabetes beginning very early, but in Arizona, 3/4 of people in this tribe over the age of 45 have diabetes. So while the overall prevalence, as you can see, is 35, 40%, that's starting from age 20 to life end. If we're looking just at the individuals who are over just 45, we're looking at 3/4 of the population have type 2 diabetes. So what we really see here is that diabetes is certainly associated with our diet, our lifestyle, and obviously there are genetic elements. And that's one of the things that we are going to recognize is that there are a variety of factors that go into why do people have diabetes. And this is just sort of one example of how a massive change of culture can extraordinarily change the rates of diabetes. One other sort of minor example point that I'll show here is that the rates of diabetes can be different. Even there's a reverse example, which is that the rate of diabetes for Chinese Americans is significantly lower than the rate of diabetes in China. So there's actually one example where here there may be a protective factor. We don't really understand why, but about the rate of diabetes among Chinese Americans in the United States is actually about half the rate of diabetes among the population of mainland China. So again, the genetics plays a role, but there can be a lot of environmental issues that can modify that. Depression and diabetes. About 17.5% of people with diabetes also suffer from major depressive disorder. Roughly breaks down to 13% of men and 22% of women. And this is about double the rate of what you see in the general population. So diabetes is associated with significantly elevated rates of depression. And you may tend to think of this as diabetes causes people to be depressed. But there's also evidence that depression may contribute to people developing diabetes. In fact, it is very much a bidirectional relationship. In the very large study in the United Kingdom called the Whitehall II study, in which they followed a group of many thousands of British civil servants over a period of many years, one of the findings of Whitehall II was that people who had major depressive illness at time 1 over the course of the next 10 years were 25% more likely to go on to develop diabetes than people who were not depressed at time 1. Similar studies have looked at this in the other direction, showing that if you have diabetes and you follow someone over time, you're 24% more likely to go on to develop depression, even if you did not have depression at the beginning. Now, when we're talking about depression here, I'm talking about major depressive disorder. And so what I have here for you is the diagnostic criteria, as many of you are familiar with, of major depressive illness. That you need 5 or more symptoms over the course of the past 2 weeks that have been going on most of the time and that represent a change of previous functioning. You have 9 symptoms. You have to have had one of the first 2, which is sadness almost all the time, and or anhedonia, a decrease in interest or pleasure most of the time. Now, one screening device that is helpful for depression, because we're going to look at depression and looking at it in the general population for people working with patients with diabetes, is we need sort of quick, easy ways to screen for the presence of depressive symptoms. And so what you have here is the PHQ-9. The PHQ-9 has the 9 primary symptoms of major depression, and it asks over the last 2 weeks how often you've been bothered by any of the problems. And if you see here at the side, you have the choice of not at all, several days, more than half the day, nearly every day, and it's identified 0, 1, 2, or 3. Any score, if you look down in the bottom corner here, all scores above 9 warrant further evaluation. So if you score above a 9, it's an indication of possible greater evidence that you have depressive symptoms. Now, I've said that depression is a risk factor for diabetes and diabetes is a risk factor for depression. So how does this potentially work? Depression contributes to diabetes, and there are a couple of possibilities. One is that medications for depression may increase the likelihood of getting diabetes. Now, older antidepressants, the tricyclic antidepressants, were definitely shown to have a hyperglycemic effect, so some risk factor from that. Currently, the reason why this may be more true is the increased use of second-generation antipsychotics, drugs like Abilify and Geodon and Risperdal and Seroquel, drugs like this being used as augmenting strategies for people with major depression. And these drugs are all fairly clearly shown to contribute to hyperglycemia, to insulin resistance, to an increase in triglycerides, and to weight gain. But those effects are actually independent of the effect of weight gain. And it's very strongly recommended that if somebody is in a risk category where they are at high risk for type 2 diabetes, that second-generation antipsychotics may be not a good advised drug depending on what else is going on, but the risk factors can be much higher. Weight gain itself is associated with increasing the risk, obviously, of depression. Depressed people are 58 times more likely to ultimately gain weight and become obese. So people who are depressed are often going to be engaging in health behaviors that are not promoting of a lifestyle that's going to help somebody ward off diabetes. Now, if you have diabetes, of course, there are obvious ways that diabetes contributes to depression. One natural issue is, as we're going to talk about in a moment, the stress of coping with the illness itself. But the other, of course, is obesity, that people with diabetes themselves are more likely to be of higher weight. And obesity is associated with a 55% increase in developing depression. So we sort of have a natural phenomenon here where each of them is contributing to the other. And the result of this is very significant when you look at the combined effect of having depression and diabetes increases a person's risks much greater over the effects of either depression or diabetes. So the combination leads to a 36% greater risk for microvascular disease and a 24% greater risk for macrovascular disease. A large study that was done reviewing the charts of 346,000 VA patients. Patients were followed over a period of 7 years. And these patients, at the beginning, some of them had neither depression or diabetes. Some of them had depression but not diabetes. Some had diabetes but not depression, and some had both. So relative to people who do not have depression or diabetes, people with depression or diabetes are 25 to 30% more likely to have a heart attack in the next 7 years than people. So these are all the people in this study are basically middle-aged. It's a VA population, so we have a middle-aged male population that's being evaluated. So people with depression or diabetes, 25 to 30% more likely to go on and have a heart attack in the 7-year period. If you have both depression and diabetes at the beginning of this, you're 80% more likely to go on and have a heart attack. So there's definitely a comorbidity, and it is well beyond just the depression is not good for you. Depression is contributing to significant changes in cardiovascular effects.